you probably haven't heard of it. So we are basically a cardiothoracic centre on the outskirts of London, so just within the M25, and we are a sort of transplant and mechanical support centre, so we only do cardiothoracics. When Toby asked me to do this talk, I'll just share the slides, so just 1 second. Bring up the slides. Yeah, the first one up. There we go. Fine. Okay, is that working? Hopefully everyone can see. So yeah, when Toby asked me to do this talk on cardiothoracics for the final FRCA Viva, it made me think about when I did my Viva quite a few years ago, and I was in the position that I had done absolutely no cardiothoracics whatsoever. I think I'd seen one cardiothoracic operation as a medical student in Manchester, but beyond that, absolutely nothing. Can I just ask if anyone is willing, can you share your video, because it makes it easier. I feel like I'm slightly going crazy just talking in a room on my own at work. So thank you for that. Yeah, so I've done no cardiothoracics at all. So I think, the first thing I would suggest is don't get too stressed thinking about what am I going to be expected to know in terms of cardiothoracics, because I think the bar is pretty low. You don't need to have seen much to pass, or any to pass. You don't need to have done any to pass. And the people who are going to be asking you questions when it comes to cardiothoracics probably did it, 5, 10, 20 years ago. So I think, as long as you know a few of the key phrases and the key things, you'll sound like you know what you're talking about, and you will likely to be fine. And you're never ever going to get anything complex from the cardiothoracic point of view. It's more about how it relates to anesthesia and other anaesthetic subspecialties, and how you would look after that, I think, is what they're going to be looking for in the Viva. So as I said, I'm a consultant cardiothoracic anaesthetist. My plan in terms of how I'm going to go through the talk is to do one long case that encompasses a lot of the themes around that I think are sort of important for cardiothoracics for the final, and then just talk through a few of the sort of hot topics, which are things that might come up, which would be likely to trip anyone up. And just by knowing a little bit about them would get you through that 5-minute Viva section without too much problem. And you don't need to know a lot about it to sound like you know what you're talking about. So moving on to the first one, it's a long case, and that was actually a case that I did on Monday that sort of encompasses a lot of the things that you would do for for a lot of the themes for cardiothoracic. So it was a 68-year-old man. He's listed for a right middle lobectomy, so right middle lobe wedge resection, a frozen section, and then plus or minus proceed to lobectomy. And the things that make it interesting were that he had a diagnosis of hypertrophic obstructive cardiomyopathy, with cardiologists had seen him and said that he's stable from that point of view, hadn't had any surgery or intervention from that point of view, so they weren't doing anything. He'd had a coronary artery bypass graft in 2011. He had prostatic CA under hormone therapy. He had hypertension, diabetes, and he was pretty big with a BMI of 45. So, in the long case scenario, what you're going to get is a presented sort of list of comorbidities, type of surgery, and relevant investigations. And what your job is to do is to really tie them up together into sort of a coherent narrative of these are the important things, and be able to come up with a pretty snappy summary of what's important, why it's important, and what you're going to do to get this person safely through their surgery. Moving on to him, and a bit more of the background that you would get would be sort of medication. So, and what you're really wanting to do here is home in on things that you can influence and change, or you need to know about. So particularly things like the beta blocker. So he's on some bisoprolol, he's on an ACE, and he's on an SGLT2 inhibitor, the empagliflozin. So all of those things are going to be relevant to the case as you sort of move forward. So as I was saying, the summary is a really important chance to show that your thinking's organised and that you've grasped the salient points of the case in that window of opportunity that you've got. So I always think that the examiners are going to mentally they're going to relax once they've heard you come out with your first couple of sentences in a really slick manner that shows that you really understand the important points of the case and you know what they're getting at. And from there, if they're relaxed, then the whole thing just becomes a whole lot easier, I think. So if I was to do my sort of brainstorming at the start of this case, what are the important things? Okay, so I'm sure as you're going through your revision towards the middle of next month, you've heard it over and over, but sort of classify or die. So I always just used to think of it in terms of preoperative considerations, intraoperative and postoperative when it comes to the long case. So for this guy, what am I thinking of? Definitely, has he been to a high-risk anaesthetic clinic? That's your opportunity to tie together all these pathologies, make sure you've got all the relevant investigations, and move on from there. Medicines management, time pressure. So this is cancer surgery. You don't want to be delaying for the umpteenth investigation that probably won't change what you're going to do. And then intraoperative considerations. So it's a hypertrophic obstructive cardiomyopathy. So basically just treat that as the same as any sort of higher risk cardiac patient. Think about what your induction strategy is going to be and how you would look after him safely. Then thoracic surgery, lung isolation, the physiology of that, and troubleshooting with lung ventilation. And also thoracic surgery goes hand in hand with with pain and how are you going to manage the analgesia for that, because that's one of the big problems that you're going to have perioperatively. And then finally going into the postoperative phase, analgesia strategy, and they always love to come up with a complication that they throw in at the end and says, how do you manage this emergency situation? So I think a common one that they might ask you about would be sort of the air leak in thoracic surgery and chest drain management, because that's again something that you would see in ITUs and after other types of surgery as well. So when I looked at that case, these are the sort of brainstorming that I do, and these are the themes that you're going to have to tie together when it comes to your summary. Just looking through it a little bit more closely. So high risk anaesthetic clinic, what's the point of that for this? So what would I say about this if I was asked about it? The dual pathology, so he's got lung condition and his pre-existing cardiac condition. So you want to know that you've tied together both of those and thought about how one might impact on the other one, and mentioned that as the point of the sort of high-risk clinic. It gives you the chance to manage the medicines perioperatively. We are the people who will tell them what to do. So, don't stop your beta blocker, don't take your ACE the day before, and particularly, empagliflozin is a drug that we see a lot more frequently now and can cause lots of problems for us perioperatively. So we say to stop it a week in advance. So if that's not a drug that you've thought about, just think about it, because I think it's slightly more topical, and that's one of those medicines management ones that comes up. And then any other investigations that you want to get before you start. So for this guy, obviously your echo is going to be important. A cardiology review in this gentleman is obviously something to think about. We had that letter already when we anaesthetized him on Monday, but knowing that his grafts are still patent and working, knowing that his echo is LV's preserved, his RV's preserved, and then he'd actually had a cardiac MRI, so that's standard for someone with hypertrophic obstructive cardiomyopathy. Now, this level of granular detail you don't need to worry about. I think if you said, I'd get the cardiologist to have a look at him because he's had previous revascularization surgery, and I'd want to know what the echo shows. Like, that already shows the level of competence that you'd be required to get you through that station. And so, I think just having that in mind, high risk cardiology review, and then the lung function. So, I think we often torture ourselves trying to remember these complicated tables from like the British Thoracic Society or in the run up to the exam. But I try to keep it as simple as possible. Functionally, what's this man like? Can he get up a flight of stairs? The answer is yes. And then the BTS guidelines is for a lobectomy, an FEV1 of more than 1.5 litres, and for a pneumonectomy, which we hardly ever do, an FEV1 of more than 2 litres. And if you pass that, then you're likely to be okay. Don't worry so much. You could mention about predicted post-operative lung function, but definitely don't get into the minutiae of trying to calculate how many lung segments they're taking out. Just keep that in mind. I think if you can say 1.5 litres FEV1 for a lobectomy, more than 2 for a pneumonectomy, then that's the sort of level of detail that is going to make you shine in the exam rather than anything else. Okay. Intraoperative, this patient had HOCM, but it could be any problem. It could be aortic stenosis. It could be unstable angina, something like that, they may concoct a scenario in which you have to give an anaesthetic to a challenging cardiac patient who, for one reason or another needs emergency surgery. So one of the things that you have to have anyway for your practice, but for the exam certainly, is a well-rehearsed way of giving an anaesthetic that's stable for a high-risk cardiac patient. And there's loads of ways to skin a cat, whether you use etomidate like we do here for a lot of these sorts of patients, or midazolam, high-dose fentanyl, and a little bit of propofol. Something like that is fine, and whatever works for you in your hands is what you want to be saying in the exam. But just paying attention to the sort of the details. So an awake heart line, maintaining CPP, well-filled patient, particularly in HOCM. All these are the sort of buzzwords that they're wanting to hear, which basically reassure them that you're not taking this anaesthetic lightly. You realize that there's consequences if you get the induction bit wrong. So you're going to take it very seriously. You're going to be all over the hemodynamics as you go off to sleep, and you're going to be sort of preempting the complications of it. And I think, again, I wouldn't worry about the, what are the really important drugs or minutiae of, I would give this or that. It's just those principles of like maintenance of homeostasis as much as possible. And that's kind of what we're doing all the time anyway. That's going to reassure them that you'll be safe to anesthetize someone like that. And don't, and then just leading on from that, the next point, the obesity, don't forget about the, the more common and straightforward things. Just because they say HOCM, well, the cardiology letter says that's fine, and he's been living his life with that for for a prolonged period of time and doesn't have any problems. Actually, the more challenging thing with this guy is going to be the BMI of 45 and trying to get a double lumen tube in. So, keeping that, not focusing in too much on one thing, but keeping that general overview. And I think that's what we're good at. We can look at all these different pathologies at once and decide what's important to us as the anaesthetist of doing that. And I think if you can demonstrate that in the long case, you'll go a long way to getting the marks you need. And we'll talk about one lung ventilation when we talk about sort of hot topics, so we can move on to that. And then analgesia. So again, this applies to all different anaesthetic subspecialties, but particularly for thoracic anaesthetics, postoperative pain and managing that is just so important, and you really need to emphasize that, because it's some of the sorest operations that you're going to do. A thoracotomy, is really deeply uncomfortable for the patient. So you want to demonstrate that you've thought about that before, even before the operation. So you give some preemptive analgesia like gabapentin, sometimes people do. Intraoperatively, are you going to start something before knife to skin with a paravertebral? Are you going to get the surgeons to place a catheter? And then you're going to be all about the multimodal analgesia. So I literally give them everything. I give some clonidine, magnesium, paracetamol, parecoxib, local anaesthetic. You're just all over that strategy with as many adjuncts as possible, aiming to get them comfortable, able to. And your pain assessment for these patients has just got to be functional. Can they take a breath in? Can they cough? If they can do both of those things, then you've done your job well. Because again, it's that risk balance of over sedated, high CO2, failing ventilation against comfortable enough breathing away, and a patient that you've got the analgesia strategy right for post-op. So for this guy, I think the important points intraoperatively are going to be, I'm going to have a nice stable induction. I've got a plan for managing that difficult airway. And then, I've got a really robust analgesia strategy because I recognize the importance of that post-operatively. Okay. And then I think they always love to throw something in at the end. Just when you think everything's going well, something happens and there's a complication. So, following chest drain removal, the patient's dyspneic. Well, that's not surprising. It can happen. And air leak is definitely something that they might think about post-thoracic surgery. So, they've injured the lung. Basically, what's happening is that air is leaking from the tracheobronchial tree, and it's collecting in the pleural space, causing a pneumothorax, and can cause compression, and that's where the dyspnea will develop. And what's the management? Well, you put a chest drain back in. So it's not complicated, but definitely think, for post-op complications of thoracic surgery, air leak post-op is going to be a common one. Then, so, it's just beware they're going to throw something in at the end. So cardiac case, it's going to be the hemodynamically unstable post-op. They've probably got a tamponade until you've proven otherwise. Whereas thoracic, things like air leak or post-operative pain are going to be the big things that they might ask you about. Okay. This is the ideal scenario, isn't it? That it devolves into a coffee room chat about a challenging case. We all like to talk about cases that were difficult or what we've done recently. And again, I'm just trying to emphasize the point that they're not really interested in the minutiae of cardiothoracic anesthesia and how you're going to manage that. But what they need to know about is the headlines, that you can do all of those things safely. And I think that case ties together quite a lot of them nicely. So, just have that sort of as a case in mind when you think about your cardiothoracics. And if you get those sort of salient points out, I think you would be absolutely fine. And again, just to re-emphasize, one thing I found really useful in the run-up to the finals was doing, just looking at all these revision books that we've got, where you've got long case after long case. Don't do every question in them, but just look at the preceding information and try and come up with a really snappy 2-line sentence that's going to be your opening gambit. That's gives you the confidence to just carry on from there and take whatever questions they give you. Because honestly, I think from doing interviews and that sort of thing, you just if someone sounds competent in the first few lines that they utter, you mentally relax and everything becomes a lot easier. So just take the time to practice those things first, okay? So short cases. Cardiopulmonary bypass. Now that's one that if it comes up, if I had been asked about that, I think I really, really would have struggled. So this is my cardiopulmonary bypass for idiots. I'm not a perfusionist, so I'm not as expert as them, but I definitely understand a little bit about it now. And this is the diagram that comes up, frequently, and it definitely looks a little bit complicated. There's a lot of arrows, there's a lot of different colors going on, and it'd be very easy to become slightly overwhelmed and trip yourself up talking about it. So I think keep it really simple. What is it? It's a machine that bypasses the heart and the lungs and allows the surgeon operate optimal operating conditions for working on the heart or the lungs. Okay. So you can do a cardiotomy. You've got a still bloodless surgical field. So that makes the technical aspects of cardiac surgery possible. So that's what it is and what it's for, essentially. It's thinking about it, I think the easiest way to approach it is to think from the venous side onwards, okay? So you hear so many different terminologies when it comes to cannulation, and I remember being in cardiac theatres for the first time and thinking, what are all these things? Why are they all different? But fundamentally, what you have to achieve is draining the venous blood before it goes back through the heart. So usually that is through what they make a cut in the right atrial appendage, and they'll put a cannula into the right atrium, and that drains blood that's coming back from the SVC and the IVC and drains it towards this venous filter. Now, there's different ways that they can go about that. They can do what's called bicaval cannulation, so a cannula in both the superior and the inferior that drains the blood. So that lets them access things like the tricuspid valve and all that sort of stuff. And they can put a 2-stage cannula in, which is one that comes up through that has a hole for both the SVC and the IVC. So there's all this different terminology, and I think you don't need to worry about that at all. Just think, the venous side of the drainage is going to be right atrium or thereabouts. It takes the blood and it drains it usually just under gravity, but sometimes with a bit of suction, into a big venous reservoir, which is the massive big venous bucket that sits at the side of the bypass machine, and that can usually accommodate up to sort of 5 liters. Okay, and so that's the first bit to think about. And then you take the blood from there, and it goes through the systemic blood pump that you can see at the bottom here. Okay, and that can be centrifugal. It can be a roller pump is the most common one that we see, and then it takes the blood and goes from there. Just move my thing through a heat exchanger, which allows you to control the temperature of the patient, and then through a gas exchanger or oxygenator, where it's gas is passed across the blood and you can oxygenate it and remove the CO2. Okay, And then from there through an arterial filter, and then it's plumbed back in with the aortic cannula, which is distal to the aortic cross clamp. So the blood is now oxygenated, it's nice and red, and it's going back in after the aortic cross clamp. And from there, it can go up, the brachiocephalic, and it can go up the carotid and supplies the rest of the viscera. Okay, so it really, like, that is as simple. That's the terms you want to remember it, and it's just bypassing the heart. All this extra stuff is just to facilitate the cardiac surgery. So all this stuff here, suckers, vents, all that does is sucks up the blood that the surgeon loses, brings it back after passing through a filter into the venous reservoir, and then can go back on from there. And then this is the next step that they might ask you about, which is the cardioplegia. So what is the point in cardioplegia? Again, I found it, when I first started cardiothoracic, same thing, all these, nomenclature and terminology. The cardioplegia is just there to facilitate diastolic arrest of the heart, okay? So you stop the heart in diastole, and what's the point in that? So it reduces the oxygen requirements, it protects it against ischemic time, and it stops the heart from beating so that you've got the surgical you've got the surgical field that you require. And how do you achieve giving that cardioplegia? Well, there's two main ways to do it: antegrade and retrograde. Now, again, I don't think you probably get down into the weeds of how to do this, but I think just understanding this bit is quite useful. If you've got an aortic valve that's competent, and you've got your aortic cross clamp on, then you place a cardioplegia cannula into the aortic root. So between those two things, right? And then by infusing the cardioplegia, and it's often like a liter and a half they can give initially, they can give a reasonable amount. They will put it through the aortic root under pressure, and then it will perfuse down the left and right coronary ostia through the coronary circulation, supply the blood, the blood supply to the heart, and deliver that cardioplegia to the myocardium. And then very soon after that, the patient will become asystolic and you'll have your surgical field ready. And then you need to repeat that every 15 minutes, half an hour, just depending on what the surgeon's doing at the time, in order to facilitate, keep those good surgical conditions. And that's one of the key determinants of how the surgery goes, is how good the protection of the heart is with the cardioplegia. So what does it do? It stops the heart. Why do, and what else? It helps protect it during the ischemic time. And what's inside it? It's usually, a large dose of potassium plus a bunch of other stuff. So buffers, it sort of protects against the ischemia, and stops to acidotic environment developing. Okay, so that's the pump covered, the cardioplegia covered, and then thinking about how do we actually go on bypass. So these are the sort of the highlights of that, I'd say. So initiation, what's the key thing with the blood needs? It's going to be passing through an artificial filter, so you're going to need heparin, so you need to anticoagulate them, and it's usually sort of 300 units per kilogram. So you need to know the weight of the patient. You need to make sure, we usually go by ACT, and once the activated clotting time is more than 450, be happy for the patient to go on to bypass. Maintenance, that's up to the perfusionist. They set the cardiac output, they control the SVR with agent like metaraminol, and they make sure that make sure that they're maintaining an adequate mean arterial pressure. And then weaning off, that's the sort of exciting bit of cardiothoracic anesthesia, isn't it? Is taking the heart starting again and taking back over control of the circulation. So you need to have a thought about what do you need for that to happen. So temperature needs to be back up, the rate and rhythm of the heart, usually we're pacing it, so then we're setting that. What's the acid base status? You want them, normal pH. And then what are the electrolytes? Potassium back in range, 4.5 to 5. And then, slowly weaning the bypass off and the heart taking over, and your inotropy and everything ready to go, so that you can ensure that the patient maintains a reasonable mean arterial pressure. Okay, so I think, and then finally the post-operative phase of bypass, what happens next? It's like a systemic inflammatory response over the next 48 hours or so, which is a bit like sepsis but then resolves. So I think, CPB is definitely one to have a look at and to have a think about, but you don't need to know super amounts of detail about it. You want to keep just to the principles so that you could answer a 5-minute question. You're never going to get more of it than that. And the person asking you about it is not going to know that much about it. Okay, so that's the first of the hot topics. Next, implantable electronic cardiac devices. You always used to sort of fill me with terror, all the different pacemakers that patients could have, what they're for, what's all the sort of complicated nomenclature about it, and what do I do with this thing perioperatively. We come across them fairly frequently. And I think it's quite an easy one for them to throw in, saying, how do you manage it and what's the potential complications of this device? So what is the easiest way to think about it? I think there's three sort of key devices that they might ask you about, okay? So the first are permanent pacemakers. And again, in simple terms, they're there to control of bradyarrhythmias and for patients who are at risk of asystole, okay? They can be single chamber or dual chamber devices. So their single chamber will either have a lead in the right atrium or the right ventricle, and a dual chamber will have one in both the right atrium and the right ventricle. Some devices will have 3 leads, okay? And that's how you know it's a CRT, so cardiac resynchronization therapy device. And that's because we know that in heart failure patients with a broad QRS complex, by pacing pacing both the right and the left ventricle and correcting that bundle branch block, you get a more physiological contraction and a better prognosis for these heart failure patients. So if you see 3 leads, that's it's likely to be a CRT device. And the way they get at that is right atrium, right ventricle, and 1 lead going through the coronary sinus that then can pace, which is where the veins are draining to, which can then pace the left side of the heart as well. So that's permanent pacemakers. They can be synchronous or asynchronous. So synchronous is, physiological. So it's pacing atria and then ventricle, and then conducting down the pathway and pacing the ventricle, or asynchronous, which are the sort of safer modes, which is pacing is like BVI. So I think don't get caught up in the nomenclature, because it's confusing to all of us except the electrophysiologists and the cardiac physiologists. I think just know what's the point in this device and what's the implications for me perioperatively. The problems that you're going to get with a pacemaker intraoperatively is that it can sense electromagnetical interference as a depolarization of the heart, and therefore it doesn't deliver a paced beat to the heart, and you're putting the patient at risk of asystole. And there's also the risk that it does pace with like an R on T phenomenon if it's a asynchronous one. So those are the 2 big risk factors, and the times that's going to be worse depends on the type of surgery. So where is it? How far is it away from the pacemaker? If you're more than 10 centimeters away from the pacemaker, the risk is definitely less. And particularly surgery using bipolar diathermy and below the umbilicus is very low risk, so you probably wouldn't need to use it. And it also depends if the patient's dependent on that pacemaker or not. So if they're not dependent, then again, that puts the risk very low. If it is, you then need to think about the nature of the surgery. Is it emergent versus elective? If it's elective, it can wait. You get the physiologist to have a look at the device and to set it appropriately. If it's emergency, then it's on you and the surgeon to decide what's the best way to manage it, and it might be discussing with them where you put the diathermy pad. Can you do it without monopolar? And you just need to have a way of balancing all those risks. So that's permanent pacemakers. The second type of device is going to be ICDs. So, yep.
Sorry to disturb very quickly. We just had one question very quickly, which says, "What does pacing dependent actually mean?"
Okay, that's fairly easy. Pacing dependent is that without the pacemaker, that they would be either bradycardic, not compatible with a reasonable cardiac output, or asystolic. So if they're pacing dependent, they need that pacemaker, otherwise it's no good. Whereas someone who's not pacing dependent is at risk of bradyarrhythmia arrhythmia. So they may have like sick sinus syndrome where their heart rate will drop intermittently low, and the pacemaker's there to catch them when that happens. Whereas pacing dependent is like, I need this pacemaker because I won't have any sort of electrical activity without it. So that's the way you would stratify that risk. Okay.
Brilliant, thank you.
No worries. So implantable internal cardiac defibrillators. So that's the reason for them is treatment of life-threatening tachyarrhythmias like VF or VT. Okay. So, and these can go hand in hand with cardiac resynchronization therapy devices. So it's usually an ICD or a CRTD. Okay. The patient needs them because for one reason or another, they're at risk of life-threatening arrhythmia. And it's there so that when that happens, it senses it, it gives them a shock. Okay. Now, obviously, during surgery, that's pretty important that we know about that because it's very likely that they will sense the electromagnetical interference and will deliver a shock inadvertently when the surgeon starts buzzing. So the way to deal with that is to get the cardiac physiology to deactivate the device. If it's out of hours, you can put a magnet on it, and most of the devices will make an audible noise that and we'll just set it to the pacing mode rather than a defibrillating mode. So if you put a magnet on top of it, it will disable that device and make it safe for surgery. Okay. And then the last thing that they might throw up as an implantable device is the loop recorders. And it's just important that the patient knows if they've got one of them that during surgery it will be recording that, and obviously the surgeon, when they analyze that, they should probably have that context when they look at it. Okay, so that's the sort of a very quick précis of implantable electronic cardiac devices, which is a very easy way for an examiner to make any case a little bit harder. So getting on to next hot topic, and I'm aware that we're probably running fairly low on time, so there's not very many left, but we've got a couple more to cover. Aortic stenosis. So it's a cardiac problem for non-cardiac surgery. Most common cause of it is calcium deposition on the aortic valve, making that orifice smaller and smaller and smaller. The heart has to generate more and more pressure to work against that narrow orifice to force the blood through in adequate quantities. And as a response to that, the heart gets stronger and stronger and stronger. It hypertrophies. And there's some, and then the problems associated with that. So it needs higher myocardial oxygen demand, and it needs really good coronary perfusion pressure because the muscle becomes quite hard for the blood to get through because the heart becomes so hypertrophy, and it's basically like a downward spiral. So why is that relevant? Well, 2% of the population above 65 and 4% of the population above 85 have severe aortic stenosis, whether they know about it or not. And it can only become symptomatic, at very, very late stages often. And a lot of the people presenting for surgery, again, elective or emergency, will have this as a problem without having known about it. So how do we manage that when we can't treat the problem definitively with an aortic valve replacement or a TAVI? And how are we going to facilitate that emergency surgery for them? So one of the things that you might be asked about is so that sort of anaesthetic goals for this. So you can see here are the problems that you get with aortic stenosis. You've got, as we said, you get concentric LV hypertrophy, which leads to increased oxygen demand, poor relaxation because of the very strong muscle, and worsening systolic function. So you have to be able to give an anaesthetic for these patients safely. How do you do that? You sort of need to make sure they're reasonably well filled. You need to maintain their afterload. So, again, this all comes back to being able to give a cardiac stable induction, have an awake arterial line, you have a big working cannula, you have some vasopressor to hand so that you can maintain that SVR. And you're just very, very cautious with your induction. Again, just by nature of the population that we're talking about, some of these patients will be presenting for surgery that we'd often do regional anesthesia for, but dropping the afterload in a very sort of aggressive way or uncontrolled way can be really problematic. So you know, if you're going to say something about regional anaesthesia, you have to say it with the caveat that, you know, that you recognise the danger that poses to patients with this sort of condition. Okay, we talked about significant values. You know, I think the easiest one to remember is a valve area of less than 1 counts as severe. So when the aortic valve is less than 1 centimetre, you know, if that's all the area you've got to get your whole cardiac output through, it's not a surprise that it's severe. And there's different ways of grading it. But I always think, you know, it's hard to remember all of these things for the exam when there's so many other things to focus on. So just think about less than 1. Okay. Now, again, a really easy topic for a sort of 5-minute one-on is one lung ventilation. We talked already about suitability for surgery. So again, remember 1.5 FEV1 for a lobectomy, 2 for a pneumonectomy. If that, you know, if they make that, then it's fine. Choice of lung isolation technique. So what do you do? Most frequently, it's going to be a double lumen tube. That's what they're going to be getting at if they ask you about this during the exam. But other things to bear in mind are putting a single lumen tube down the main bronchus, which can be done if you need to do it as a sort of emergency and you've not got the equipment, or using a bronchial blocker, but they're not going to know how to do that or ask you too much about that, I think, in the exam. So double lumen tube is what you want to know. Sizing of a double lumen tube, something again that used to stress me out. It's like, well, you know, there's all these formula. Actually, it makes very little difference what size of double lumen tube you do, and you can find an evidence base for giving everyone a 35 French to giving, you know, sizing up by looking at the CT and measuring the diameter of the bronchus compared to the, you know, circumference of the double lumen tube you're pressing down. So please don't get caught up on that. The easiest way, and what I actually do in my own practice, 37 French for a woman, 39 for a man. And if it's, you know, when you look down and it doesn't fit, you can upsize or downsize, but pretty much that is what I do for every single case. So, you know, don't stress yourself out by trying to make it more complicated than that. Positioning of a DLT. Okay, so again, you know, you might be torturing yourself thinking, I clamp this, I clamp that, I, you know, ventilate this lung, I ventilate that, I do pressure control, I look for a drop of this or that. Again, okay, you can do that, but, you know, the very safe answer is that I would position it using a, you know, a fiber optic scope. So the way I would do it, and the way I'd encourage you to explain what you were going to do, is when you've intubated the trachea, you take your scope and you put it down the bronchial lumen, so it's coming out of that. You identify your landmarks, so you get to the carina, you know which is left and right. But if you really want to make sure, you know, you can say, I would look for the right upper lobe to confirm that that is indeed the right main bronchus. And then you would put the scope down the left and feed the double lumen tube over it. Then you would look down the tracheal lumen and just make sure that all you've got is a hint of the cuff at the, you know, at the entrance to the left main bronchus. And that's as simple, you know, that's how simple it is and how easy it would be to, you know, place the DLT. You don't need to worry about, you know, checking clinically. If you've got a bronchoscope, make use of it, and, you know, and then it becomes a lot easier. And I'd say that most people would do that. You know, you wouldn't be looking in a DLT without one unless it was an emergency. Positioning, you know, again, it sounds very, very, very much convincing if you can say what you would be planning to see. So that mention of the right upper lobe, or mentioning that, you know, when you're looking down the bronchial lumen on the left, that you're looking for the, you know, you're looking what your bronchoscopic anatomy would be, and just small picture of that will help remind you of what you're looking for. And then the thing that they would always move on to next is management of hypoxia during one lung ventilation. So the typical story is it's going well, you've got your DLT positioned nicely, and then the surgeon makes the incision, you know, releases that nice, you know, negative pressure, and everything collapses onto the dependent lung, and the patient starts to become hypoxic. How do you manage that? So first thing is, you know, increase the FiO2, but it's shunt usually, so it doesn't always get better with that. The most important thing is if your patient's hypoxic, ask the surgeon to stop, tell them that you need to reinflate both lungs, get yourself to a position of safety, and then check the position of the tube, because it's almost inevitable that that is the problem. It's usually moved because of one thing or another, turning the patient or the surgeon manipulating it. You've usually dislodged it and you're not ventilating in the way that you think you are. So check the position. And then once you've dealt with that, there's a few other tricks that you can play. So you can manipulate the ventilation. So you increase or decrease the tidal volumes, increase or decrease the PEEP, see, change the rate. If that doesn't make much difference, you've got a sort of set of escalating things you can do. You can insufflate down a little bit of oxygen down the non-ventilated lung. So you can put a suction catheter with 2 liters of oxygen sort of taped to it and just let that flow into the lung. And that often buys you a bit more time before the patient will desaturate again. You can actually attach a CPAP valve to that lung, and it just, goes up to sort of 10 centimeters of water CPAP. And the surgeons will usually tolerate sort of 2 to 5 of that. And that usually makes things much, much better. You can just do things intermittently. So you might need to ventilate for a bit and then let the surgeon operate again for a bit. Then the fallback would be in the books is that, the clamp the PA. Again, I've never had to ask a surgeon to clamp a PA for me. Usually, the worst that it gets to is CPAP, and you can usually get away with it. But that's the sort of series of steps that you would follow. And that's pretty much it for, again, keep it really simple how you would manage hypoxia during one-lung ventilation. In reality, I find that, it is very rarely a problem. And one of the things that helps with that, I think, is TIVA, because you've got better VQ matching, but that's just an aside. Okay. Finally, it wouldn't be a talk from Harefield without mention of this. I don't think it's going to really come to this, but one thing they do love to throw in is the transplanted heart, because the whole thing about it denervated, if you give atropine, it won't do anything. So you use adrenergic things, so give some adrenaline or isoprenaline, and it might help. And just throw that in because they often ask, they often put in a transplanted heart for other non-cardiac surgery. So that's just one to be aware of. Mechanical circulatory support, most common one that they might ask about would be a balloon pump. So diastolic augmentation. You put it in, it increases the coronary perfusion pressure by inflating during diastole, and it can help patients with unstable angina. But again, it's a small note. I don't think they would know, in great detail about IABPs, and you wouldn't be expected to know more than just a sort of superficial knowledge of that. And then the other stuff is more what to do in the event of disaster. So Impellas and ECMO are mechanical circulatory support. VADs, again, sometimes you get patients presenting to peripheral hospitals, but usually you would just want to be able to demonstrate a safe approach, phone the specialist centre, get advice, and balance the risk of doing these not doing. And I think that is pretty much it. And I think that's me also at 45 minutes. So I hope that was useful to you. It's difficult doing it, as a talk rather than just a viva with people. So I hope some of those things come good for you come the exam in June. So best of luck with it. Please feel free to email me. My email is at the bottom if you've got any questions with regards to cardiothoracic anesthesia. And also, I know that there's a few people who have come from Bristol who are interested in cardiothoracics coming to Harefield for fellowship. So if you're interested in it, please do get in touch, because we organise the fellowships here. So I'm always happy to help.
Chris,
and
thank
any
you.
questions?
Chris, can I ask? There is one other question that's come up.
Oh yeah, sure.
Can I retry? And if it's too long, then we can do it via email. But the question was, can I ask about ICD action in tachycardia? Is the response to shock or to overdrive pace? If overdriving pace, how does that actually work?
It's a good question, and one that is, again, one of those things that is difficult to actually. I'm not 100% sure on the answer, if I'm being honest. It's these minutiae of pacing devices are really for the EP physicians and the cardiac physiologists. They know what they're doing with it. So I think that the overdrive pace is the answer to that, but I can't be 100% certain. I can look into it and I can get back to whoever it is by email, but as for a definitive answer, I'm not sure. But would you be expected to know that in final FRCA? I don't think so. I think you've got that sort of superficial knowledge of permanent pacemaker and ICD and what to do with them perioperatively, then I think you're fine. And actually, there's just been some new guidance by the GBI and the Society for Cardiac Implantable Devices about management of those perioperatively. So I think we'll probably get an answer there.
That is